All right. Good evening, everyone. Thanks again for joining in. Apologies for the slight delay. We are waiting for the presenters to join the session. I think we have Geeta on board as a panelist, so maybe we can start with her case. I think we have around 6 cases today with 2 follow-up cases. Should be an interesting session. Feel free to put your suggestions on the chat. The diagnosis, any other suggestions also are welcome. So without further delay, we'll move on to our first case. If Geeta is there, we can directly go to her case. Yeah, over to you, Geeta.
Yeah. So this is an 8-year-old male child who was born out of third-degree consanguineous parents. So there were no perinatal issues. He was developmentally normal, but he had a significant family history of 2 previous siblings' death. One was a female, one was male, around 1.5 years and 4 years of age. Complete details are not known here. So he presented to us in the month of April. So with the right focal motor status, almost the status was there for approximately 2 to 3 hours. And then when he presented, he had a secondary, it was GTCS. So causing the hemodynamic instability for which he required ventilatory support and all. Though he was on a minimal settings, he didn't require much. And post this, he had a febrile illness, but it did not start with any febrile illness. So during that day, we have noticed that there were paucity of movements on the right side of the body for the painful stimulus, but which recovered within the 24 hours. So first MRI was done on the around day 1 to 2 of the illness.
Okay.
So shall I tell further after the MRI?
No. Yeah, I'll show the images. All right. So first MRI on top is the diffusion rate sequences. And you can appreciate on the diffusion, the positive findings are in the left hippocampus. Some areas of restricted diffusion demonstrated out there. Coming down to the flare sequences, you can appreciate that there is these T2 hyperintensities, these large extensive abnormalities involving the insular cortex on the left. Then you have the deep brain nuclei involvement, the central white matter.
Groups are randomly selected. बराबर है simplest way में तो आज से ना.
Yeah, so okay, then extending up to the basifrontal regions, possibly on the right side too, but yeah, more predominantly on the left side. Also involving the right amygdala out there. So bilateral medial temporal lobe involvement, but more predominant on the left side. And if you can observe that there is some mass effect on the ipsilateral cerebral peduncle by the left hemispheric temporal lobe abnormality. On the T1 weighted non-contrast sequences, the abnormalities are predominantly hypointense, some areas of isointensity too. Again, you can appreciate some degree of mass effect out there with the effacement of the cisterns. Coronal sequences again demonstrate the similar changes which are seen on the T2 axials. Again, predominant abnormalities in the temporal lobe. Post-contrast, there was no enhancement. None of these areas demonstrated any significant or enhancing foci. SWS sequences did not demonstrate any areas of blooming. Spectroscopy was done, and spectroscopy demonstrated you have a lactate peak out there, possibly an elevated choline, but the Na peaks were relatively normal. Some lipid peak out there. Yeah, so the main findings were a lactate peak, a lipid peak, and maybe an elevated choline peak, but the choline to Na ratios were normal. The choline to creatinine ratios were not very significantly altered. At this point of time, yeah, Geeta, you can just take it from
post
there.
this, we have done a workup for the inflammatory and infective. CSF was normal, and NMO-MOG was negative. So he had EEG wise, he had left hemispheric dysfunction. Only after about the 4 days, the EEG became normal, but he continued to have on and off seizures in the form of sudden behavioral arrest, unresponsiveness, and decreased speech outputs. But there was no any motor impairment, and according to that, anti-seizure medications were titrated. But again, the seizures were continuing, and next time, within 20 days, he presented with focal, again, non-motor status. So that time, a repeat MRI was done. And also before this, when the EEG was done, EEG was showing a diffuse cerebral dysfunction with poor sleep markers.
Okay. So follow-up scan, interval of 1 month, is that right, Geeta?
Not interval of 1 month, around 20 days.
Okay. Around 20 days. Again, on the diffusion on top, you can appreciate now more extensive areas of cytotoxic edema involving the cortex in the temporal regions, parietal region, and the occipital region on the left side. The pulmonary thalamic nuclei also demonstrate the area of restricted diffusion. And again, you can appreciate the involvement of the extensive involvement of the insular region, the deep brain nuclei on the left side, the central white matter, the posterior lymphadenal capsule, the temporal lobe, predominant temporal lobe involvement, and compared to the first scan, there's no more additional involvement of the mammillary bodies out there, the basifrontal region on the right side, and also the medial temporal lobe on the right side. So there is some progression in these flare abnormalities in comparison to the first scan, and these diffusion changes on the left mid and posterior hemisphere, and also the thalami. Post-contrast T1 sequences, no abnormal enhancement. SWIs did not demonstrate any abnormalities in terms of blooming. Sorry, I didn't put the spectroscopy here. I think spectroscopy demonstrated a significant elevated choline peak, reduced NA peaks. Lactate peak was also there. After the second image, I thought possibly we're dealing with diffuse glioma, given the extensive involvement and the progression in comparison to both the scans. Inflammation was the other differentials to thought of. I can see in the chat that MELAS has been kept. That was also considered. Paul G mutation and MELAS for the epilepsy, but the imaging on the flares, the extensive abnormalities and the mass effect, I don't think was typical for only MELAS causing these abnormalities. The diffusion changes can also be due to cytotoxic edema related to the status epilepticus or seizure-related changes. So the question is, are we dealing with a dual pathology of lesion in the background of a metabolic mitochondrial disorder, or are we dealing with just neoplasm with post-ictal changes? I'll open the case. The follow-up, I think the child has gone for genetics,
So
is that right?
follow-up, like we have done we didn't do a CSF lactate. We have done a serum lactate, which is elevated, and so with the diagnostic dilemma, we even have sent genetics from him. They are awaited. So here our question is like whether it is a simple MELAS or diffuse glioma, and what is a like diagnostic workup that we have to do, because both are associated with a poor prognosis, and how we can help this family, because already there is a loss of 2 children. So what is the best possible things we can do for this child?
Yeah, I'll open the case.
Has a biopsy been done?
No, biopsy is not yet done. So
Biopsy
we
has
have
been,
sent...
yeah. Sorry, go ahead, Geeta.
So because there is a diagnostic, whether it is like a single or a dual pathology, so we want to take an expert opinion here. Biopsy is in the plan, but so whether we have sent the genetics, so should we wait till the genetics comes and do the biopsy, or should we straightforward go to the biopsy is the question.
Sorry, I just joined in, but the question was a very binary question in terms of what happens with the rest of the family. Then I think you should go ahead and do a biopsy whilst the tissue is still active and swollen. It might even tell you what inflammation is going on if that's the only process.
Dr. Mangal, just a question is they're looking for as MELAS, but we still do a biopsy if the genetics comes out as MELAS, right?
I mean, dual pathologies are rare. I can see that there are bitemporal changes, and I think somebody has raised the point of autoimmune encephalitis, etc. So, yes, I wanted to ask you: did you pick up any calcification in these areas at all?
No calcification, no enhancement.
But is it on a CT-based process for calcification or MR?
No, just MR.
Just MR, okay. It is bilateral temporal, right?
Yeah, temporal and also involving the left basal ganglia thalamus insular cortex of the basifrontal, yeah.
Yeah, you can wait, and if you get MELAS, then you can. Question is what your target for biopsy and your yield will be the highest when the tissue is still active. If it all burns out, then you might not be able to get much out of it. Sorry, I was late, so I don't know where the Mela's theory came from.
Geeta?
So the question is, so we have both, like it can be a Melas or glioma. So should we wait till the genetics comes and then go for the biopsy, or straightforward should we go for the biopsy is the question.
No. Clinically, does it match into Melas? Is the question.
Because clinically it is matching.
How does it match clinically with Mela's?
Only thing is, though the normal development, it is a new onset epilepsy and third degree consanguinity and lactic acidosis is the only pointers clinically.
So after the first scan, the
And there
lactate
was
was normal.
a stroke, like, so first episode when he was admitted, he had a hemiparesis, right? Hemiparesis almost, it was lasting for about 10 to 12 hours.
Okay, I mean, I was trying to see how strongly you felt about Melas, but if you're thinking then it's worth waiting, there's no rush to do anything. But while you're waiting, just make sure you do at least a flare axial Nihaal on a follow-up to make sure this is not just progressing badly in the background. I guess they're on the cocktail regime anyways at the moment, right?
There are 2 scans and it has progressed on the second scan 20 days later.
No, but if they're still waiting
Okay.
for Melas to come back, that's way.
Okay.
To be honest, even high-grade gliomas to progress so much in 20 days is a bit unusual. It takes its time. It's not that rampant. And I'm sure somebody will ask you now what the perfusion and spectroscopy is doing on this.
The first spectroscopy wasn't, highly suggested, but second, I did not put up the images, but second, I had a definite choline elevation with reduced NAs and PRTs. We didn't do a perfusion.
So the lactate is probably because of the seizures, right? Blood lactate. MRS, does it show lactate peaks in the second one?
Yes.
Second MRI.
Not as significant as the first one, though.
And do you see midlines? Do you see a mass effect in mitochondrial disorder?
Yeah, that was little atypical. That's what I thought.
This just doesn't look like Melas at all, this MRI. All the diffusion restriction is secondary insult due to the seizures.
Yeah.
And this is more like a glioblastoma multiforme sort of itch. Because Melas is so different from this MRI. At least the
That's
ones.
true. That's
But
why I
yeah.
asked why. Yeah.
Yeah, sorry.
And how did the other 2 SIPs die? Because I didn't.
So post-febrile illness, sir. So not much details are available, but they were developmentally normal. Just post-febrile seizures, within a couple of days, they expired.
Both of them.
Both of them.
What
One
age?
was at 1.5 years and 4 years of age.
So first febrile illness, first febrile seizure.
Yes. There were no seizures at that time.
Oh, no seizures. So they had febrile illness and hypoglycemia. We don't have that.
Not much details known about that.
It's a very strong family history to ignore, though, right? In terms of gene testing, what else have you done? I mean, do you have an inflammatory panel? Are you looking at CSF-IR and things like IRAC4 given its location? What is the bandwidth that you're covering?
In CSF?
No, in terms of the testing, the gene testing, the panel.
We have sent for a whole exome and the mitochondrial.
No, what
So
all
among the
acquired etiologies are ruled out?
Sorry, I didn't get you.
What all acquired etiologies have you ruled out? That's what
But
Dr. Satish is
etiologies or
finding.
infective and demyelinating, I have ruled out.
What was the CSF finding? Sorry.
CSF is normal. It's normal protein and sugar. Cells were only around 2 cells.
And protein?
Protein was around 30, I suppose.
Right.
Mhm.
Because two febrile illness children dying suddenly in their first episodes, that in mitochondrial, it's more with trifunctional protein deficiency, this NOL. There are 2-3 conditions, mitochondrial disorder, where suddenly you can die, like in fatty acid oxidation defects. But there are few mitochondrial disorders, but you won't get this type of, definitely not in MELAS. You cannot die, at least. So if those 2 children also had MELAS, very odd, at MELAS usually doesn't present at 1 year age. It comes on, the symptoms come on much later. So if you think this is MELAS, and the other 2 to be MELAS is difficult to convince yourself. Helper's disease, yes, can present. Was the liver function normal in this child?
Everything, other systemic, it is normal.
Liver function test was normal.
Normal.
Right. So, and the child has never been on valproate?
Never,
None of them.
never on valproate, no.
And this MRI is not like helpers either.
Mhm.
Have you sent a routine exome or a rapid exome?
Rapid exome. Rapid
So,
exome max we have said. So we are
so
going to
within
get
2 weeks,
the
the
report
report will
in
be
10
available.
days.
Tell me something. What are you losing by doing a biopsy if someone is willing to do it right now?
Um,
I'm not pursuing the glioma side, by the way. I'm more concerned about this being a very bad immune-mediated inflammatory process, by the way, from my perspective. But I don't know how much your gene panel will cover those possibilities, and at least your biopsy will exclude an important possibility for you.
yes, that is the question. So should we rush and do the biopsy, or because if both conditions are coexisting, it is like a poor prognosis.
What does the MR spectro show?
First one, let's see. The first one has some lactate and macromolecular lipid peaks. The choline NAs were normal, but second one had, more significantly elevated cholines, reduced NAs. The lactate was not as significantly elevated as on the first scan. And the normal-looking MRI, normal-looking lesions also did not demonstrate a significant lactate, as they thought of MELAS was
There's
there.
no diffusion restriction, right?
There is, but the child also had, so the second scan, there's restricted diffusion on the left hemisphere.
Yeah, yes.
So the child had a prolonged seizure episode. So this can be, I thought this can be post-ictal too.
Yes.
Dr. Udani, sir, your patients with hyper IgM, did they have similar MRI? Slow virus?
Well, they started off like that, but this seems to be, it's possible because the patient had, that particular patient had what looked like non-restricted contrast enhancement, which is unusual in AML. And again, it was very much like this effect, but the white matter was more involved. Over here, it's like the cortex is more involved. Cortex subcortical white. So it looks like maybe it could well be a post-ictal, but I think this absence of choline, would it go against the glioma?
No, there was elevated choline on the, let me see if I can, on the second scan. This scan, I have not put up the spectroscopy, but there was elevated choline.
And what conditions give us to increase lipid lactate besides mitochondrial, the lactate peak? Besides that will be just, is it non-specific?
Yeah, any inflammatory changes, anything which causes aerobic metabolism, lactic acidosis, PMLs can also cause them. Yeah.
So could it be a tricky, it's mainly in the gray matter. What's the story? Just acute, I'm sorry I joined late.
Geeta, do you want to just,
Yeah.
let me see if,
So this child with previously normal child presented with the right focal motor status. Almost that status was there for about 2 to 3 hours. So needing the ventilatory support, and post that he had a paucity of movements of the right side, but recovered within 24 hours. And then later on, he continued to have the seizures in the form of behavioral arrest and speech arrest and just the focal eye deviation. So this first scan was the first one, and post 20 days when we have repeated the scan, because there was a prior status to that, it was showing a worsening and elevated choline and also.
Because she's born of third degree consanguinity. The baby, she's 8 years old, right? He's 8 years old.
Yes, he was 8 years old.
And normal before this, completely.
Normal before this development, everything was normal.
No microcephaly, na?
No microcephaly.
Not yet.
Then unlikely
It will
to-
become microcephalic. All this is going to gliosof, isn't it?
Can there be
And-
primary HLH? Can it present like this? If those two children also had,
I mean, at least the contrast and the SWs are not matching.
not.
The question of autoimmune encephalitis, will it produce this mass effect was another.
In its angry state, yes, it can, because it is at the end of the day an inflamed tissue, right? So I don't think that can be taken away. And in fact, even high grade gliomas don't all universally uniformly restrict. We know that. So I would push hard for a biopsy here, so you at least have a binary plan in terms of where do you go with this. Everyone is stuck, right?
Sorry. Could it be a tumefactor demyelination? I know it's more cortical, but is it possible?
No, I don't think so. But your biopsy will give you that answer, right?
No,
Okay, so
immunotherapy was given to the child?
Pardon?
Immunotherapy?
Yeah, only steroids were given.
And after steroids, this can worsen.
Yeah.
Yes.
I
So
think I agree
initially
with
he
you.
had
Biopsy is the best option, frankly.
And if you don't want to do a biopsy, do you have choline PET MR? Or some
No, we
amino
don't.
acid PET MR? Okay, that
No,
might be the other option.
How does that help? Can you tell us?
So it's the protein turnover in a tumor, and they're quite sensitive for tumor detection, particularly the amino acid PET MR. I'm sure Bijoy must have it in his center out there. Bijoy, you can also tell us how you all do it, when you all do it.
No, we don't have a PET scanner in our center. Nor we do
Okay.
nearby. It is not available. Any amino acid PET is not available.
Okay, but you agree it might be quite useful in situations where we are thinking inflammation or tumor, isn't it?
I'm not very sure whether it is going to differentiate between inflammation and tumor.
Only the amino acid ones, not standard PET MR.
I have no idea whether it is really
But if it's not available, then there's no point discussing. But we found it quite useful in some troubleshooting situations where choline itself or ammonia and all that, those kind of traces. But if you don't have it, there's no point discussing it. Go for a biopsy and close the deal on this.
Yeah, sure.
Okay.
Yeah, thanks for the inputs.
Yeah. All right. Let's see. All right. Let's go to our first case. Okay, Dr. Ek, over to you.
Sorry. Can you hear me?
Yeah.
It's a 9-month-old baby who had fever for a month on and off and was being treated initially on a quarterly basis. And then fever persisted, and then he had a right focal seizure followed by right-sided hemiparesis. And following this, we got admitted in our hospital. And the child just had one seizure, and the hemiparesis was the issue, but otherwise was fully conscious, and the problem was the fever, which continued. And that time he had this MRI done. So, yeah. Because the other tests are not that important. It's just this MRI and then the CSF also.
Got it. So MRI diffusion, you can appreciate multifocal abnormalities, bilateral hemisphere, more confluent abnormalities in the subcortical cortical regions on the left frontal perisylvian region, temporal lobes out there. Also some foci in the cerebellum along the midline. No, I could not appreciate any extra-axial abnormalities in terms of diffusion changes. Yeah, so main abnormalities, multifocal abnormalities with confluent abnormalities in the left hemisphere. On the T2 scans, there's some degree of volume loss with associated lesions out here, heterogeneous, predominantly T2 hypointense, as you can see out here in the left parietal region. Also along the right hemisphere, the basal ganglia, the right caudate nucleus, periventricular regions, the occipital region has more of a T2 hypointense with some degree of hyperintensity and some degree of perilesional edema. Cerebellum also has these punctate T2 hypointense foci with perilesional edema. T1 non-contrast sequences demonstrate the lesions. Some of the lesions have T1 hyperintensities within them. SWS sequences again demonstrate areas of blooming more towards the periphery or along the capsule. Post-contrast, some of them are conglomerated, demonstrating predominant peripheral enhancement. Some of them also have some internal septal enhancement. I think spectroscopy was done, multiple peaks, multiple foci was kept, and you can appreciate that there is a lactate peak, a lipid peak out here. Yeah, predominantly a lipid lactate peak is what I could appreciate. Some choline elevation, possibly some peaks around D3 point. I mean, over here around from 3.6 to 3.8. Again, better appreciate on these sequences. So at this point, we're thinking of infection as the possibility. The main question was which infection does it fit into? Is it pyogenic, tubercular, or a fungal lesion?
His CSF revealed 32 cells, 70% polys, and raised protein.
Yep.
And I think it was protein was 152. And sugar was normal. We did his tuberculosis workup, whatever it was feasible was negative, including gene expert. And his CSF fan fungal PCR was negative, but his galactomannan was raised in blood, 1.22. Normally less than 0.5 is negative. So, and the child had already received, before he came to us, meropenem and vancomycin for 2 weeks. So there was a possibility about pneumococcal as well. So that was already given, and the fever was still persisting. So we're really confused if we are dealing with tuberculosis or aspergillus, or some atypical bacteria.
There's some peripheral hemorrhage, right?
Yeah, there is peripheral. Is that specific for aspergillus, or that can be seen like a macrophage activation? Is that right? In the lining of the inflamed blood vessels, which can be seen even in tubercular or a simple bacterial abscess? Nihaal, or is it more in
tubercular? I mean, I would say more in favor of sepsis-related conditions than fungal, as far as I'm concerned. I have not seen tubercular with such extensive
hemorrhage in the wall. And with fungal? Yeah,
fungal, yes. Fungal and sepsis-related conditions, the bacterial conditions. Yes, yeah, these are two primary ones which I thought of.
Could this be a septic emboli, and from somewhere the heart is okay?
Yeah, echo was normal. That was done too.
What about nocardia?
Yeah, there was a mention about nocardia, Nihaal.
Yeah, mention nocardia, fungal versus toxo by Dr. Vijay. atypical fungal, TB, HLH was
Ferritin
raised by
was
Sridhar.
done. Ferritin, there was never bicytopenia. Ferritin was 550, so it's not that high, which is just like the acute phase reactive, because that was also thought of, HLH.
Hina asks if galactoman is a non-specific finding in our patient.
Yeah, that's true. But the thing is, imaging wise, there was not many leads. There weren't many leads. So it's just whatever we could find positive. And do
Is
you
the
get toxo,
immunoglobulin
acquired toxo?
immunoglobulin profile is done, sir?
Yeah, so immunodeficiency was definitely considered, and immunoglobulin profile was normal, but we didn't do the flow cytometry and that stuff. So, but the
Because
basic
saw
profile
one
was
patient
normal.
recently who had some similar picture but had hyper IgE syndrome. So we could not identify any organism, but yeah, in hyper IgE syndromes, this atypical nocardiosis and all those things have been pseudomyeloid Burkholderiosis and all those things are happen.
So something.
But,
So job
but he
syndrome.
also
So
had
they don't present with like cold abscesses. They present so early at 9 months of age.
yeah. So that child, that's what I'm telling. That child also had
Right.
empyema. So with empyema, it was admitted under pediatric only. But once the child developed seizures, we did a scan, and scan showed this abscesses, multiple
How old was
microfocal
the child?
abscesses. The child is 18 months old.
Okay. And do they
18
have like
months old. So,
eosinophilia also? Do they have job syndrome, hyper IgE usually?
sir, he had eosinophilia. He was being treated with atopic dermatitis under ped-derm since 6 months of age.
Okay.
So initially started as recurrent dermatitis, atopic dermatitis, then had this recurrent pneumonia, then empyema, and then seizure
That
with
is very
multifocal
suggestive
abscesses.
of jobs, this dermatitis, lung involvement, and then CNS illness. Because this child just had a CNS illness with fever for a month, a well-thriving child.
Okay.
I'll go back and look in the and they would often have eosinophilia, and then they
Yes,
get
sir.
these cold abs. Yeah. But I'll go back and look at the, but those were normal immunoglobulin because that includes the IgE as well.
Okay, then unlikely, sir.
Is it
So could
possible
it
to
still
get
be
a
bacteria?
microbiological, in the sense, get it from one of those abscesses? Or is it
So family
Yeah.
didn't agree for brain biopsy.
not brain, but they can,
From?
a lot of these abscess kind of things, basically, is there anything peripheral or anything which can be easily accessed?
No,
Nihaal,
yeah.
sorry.
That
Can
was
we
it,
see
yeah.
the post scan zoomed?
How do we zoom this? I have not zoomed before.
That's okay. Okay. Can we see the diffusion and ADC also?
Yeah. I have only diffusion. All of them restrict. I mean, whatever is bright restricts.
So then it is very
Cytobacter abscesses can have such finding, na, sir? Cytobacters can have sort of these things.
I don't know whether the hemorrhage is marked because almost all the wall is hemorrhagic.
Cytobacter usually larger. I mean, at least what we have seen, more along the medullary veins predilection. With those internal striations. The gram-negative bacteria, I guess.
Can toxo present this early in a 9-month-old baby? If immunocompetent?
Only thing against is that the hemorrhage is peripheral,
Hemorrhage.
and the hemorrhage can occur in toxo, but the problem is it is diffusion restricted in the center. I thought the hemorrhage is producing the diffusion restriction. Otherwise, toxo usually will not have this much of diffusion restriction. Fungus also peripheral restriction is not seen; it's a central restriction. So the embolic, the septicemic embolic is a good thought, I think.
Okay.
Is the blood culture done any chance?
So nothing had grown in the blood or the CSF culture. echo was normal. So these lesions which are now ring enhancing could just be some bacteria, right? Still.
I remember we had a patient who actually had these multiple abscesses in the brain. They were much smaller than this, and they were not hemorrhagic. And he had fever, and that was the only thing. Neurologically, he was normal. And to make a long story short, we just could not find. He was given antibiotics and all this, and there was nothing to biopsy also. So finally, we did a PET scan, and we found that there was some sort of hypermetabolism in the spinal area, lower spinal canal. And we actually went and did a biopsy. I mean, we went over there and removed all the pus, and there was actually nocardia. And of course, that was a peripheral thing. So I don't know whether a PET scan would help in the sense to localize infection from somewhere else, which you can easily access for a biopsy, for a microbiological diagnosis.
Okay.
When we give a Septran trial empirically and Septran plus doxycycline trial, maybe that might help for atypical organisms if the fever responds.
Right. So just as a clinical radiological diagnosis.
Yes, sir.
We had
If the
actually
fever
sent the
responds,
child
then
home on meropenem and Vanc to complete and voriconazole, thinking that this tool could be a aspergillus or a. So they had gone home. So when they come for follow-up, we'll see how the child is. Because child was otherwise very well. So our differential will still be sepsis leading to bacterial process, and fungal is not a possibility, and atypical bacteria. Fungal is unlikely.
I think from the all of considering every aspect, I think fungal is less likely now.
Okay.
Okay. Dr. Vivek, if you have a follow-up, the child response treatment and a follow-up scan, that will be helpful.
Sure.
Okay, Dr. Poshan, if you're there, go to you.
Nihaal, can you hear me?
Yes, please go ahead.
Thank you. Good evening. I'm Poshan Gidet, neonatal consultant from Mangpura, Hyderabad. I have a baby who is now approximately 20 days, that's 3 weeks old. This is a twin two. Sorry, it was mentioned as 10 days, but that's old information. DCD an IVF pregnancy, second gravid, first baby died following gastrostomy surgery complications. And during antenatal period, the fetal medicine scan showed cyst in one of the twins, and that gradually increased, for which that's ultrasound measurements were monitored. And then had also antenatal fetal MRI, which we'll discuss that in detail. Baby delivered, and we did an head scan and postnatal MRI. That will come to that in a minute. But on clinical examination after delivery, baby is very well in terms of not much of cardiorespiratory support required, and neurologically unremarkable, with the head circumferences on the 91st to 98, and the weight is on the 75. And just be it to fill the gap, the other twin is doing well with no clinical examination findings often to note. And now maybe I'll ask my question after the Nihaal's comments on the radiological. Thank you.
Yeah. All right. Thanks, Dr. Poshan. I have the fetal MRI and the fetal and the postnatal MRI. Because fetal MRI, I've only put the abnormal twins images. So you can appreciate at the third trimester scanning, you have these large CSF intensity cystic lesion along the interhemispheric region. Large interhemispheric cyst is what we thought of. The corpus callosum was not visualized on the SAT sequences. The one hemisphere was slightly larger, and there was slight asymmetrical ventricular dilatation on the opposite side. The coronal sequence, again, you can appreciate that this large CSF containing cysts causing some mass effect on the FARCs and the contralateral hemisphere with agenesis of corpus callosum. Based on that, postnatal scan was done. And on the postnatal scan, again, you can appreciate this large CSF intensity cystic lesion along the interhemispheric region extending onto the right hemisphere. Also, if you can appreciate, there is some degree of malformation out here in the parietal and the posterior frontal region, some degree of polymicrogyria is what we thought. Again, some asymmetrical dilatation of the occipital horns, and possibly the right hemisphere also here is slightly more large compared to the contralateral side. Again, the corpus callosum was not visualized. Yeah, so the main findings, what we thought was interhemispheric cyst with corpus callosum agenesis and a malformation on the right hemisphere. Going by the Barkovich classification, we thought that this was a type 1 interhemispheric cyst, just communicating with the lateral ventricles, but was of CSF intensity with associated malformation. So these are again differentiated into two types. Again, as subcategories A, B, C on the type 1s and A, B, C, D on type 2s. They can be multiloculated, have different signal intensities, which can be associated with the malformations as described over here. The main question, I think, Dr. Bhushan, over to you.
Yeah, thank you. And the latest update, clinical update, is that baby remained well, and though it's a very short duration, 2 to 3 weeks, but head circumference remained static. Just to mention, my question is, considering the antenatal and the postnatal correlations, then do we need any intervention? Of course, in addition to monitoring neurodevelopmental as well as the head circumference and anything that we need to do, if so, what? Thank you.
Yeah, so any experience with these malformations and treatment related cases open?
Is it a boy or a girl?
Is a boy. The abnormal twin is affected twins. Apologies. Affected twin is a boy, and the unaffected is a girl. And the DCDF discordant twins. That's a boy that's affected twin was 2.9 kg, and the girl, the unaffected, is 2.3. Sorry, I forgot to mention, we were looking into mother's platelets during the pregnancy and all preconception to rule out any neonatal unknown thrombocytopenia, which was normal, and even we did for the baby plotting as a baseline CBP, the platelet count, which are unremarkable with no external stigmata happening in the heart.
Either raises the possibility of Chudley-Maclose syndrome. I think they have a more corpuscular appearance of the lateral ventricles, polymicrogyria, heterotopia, inferior cerebellar hemispheric dysplasia. I thought this fits more into the agenesis with the interventions.
So this agenesis and interhemispheric cysts, they usually do well in sense they don't require shunting and all, but some developmental delay learning needs may be there. And macrocephaly, which remains stable, they don't progress that way. But the MRIs, the baby walks coming to the OPD, but the MRIs look more plastic. That's what our chief describes it as.
Did you say macrocephaly or microcephaly? Sorry, maybe yes.
Macrocephaly.
Okay.
So
okay.
as far as intervention is required, intervention may not be required, but yeah.
I see. That's
They
reassuring.
require neurodevelopmental monitoring, and it is reassuring to them.
And did you say that's a microcephaly? That's, I mean, it's on the 19th century, probably because of the cyst that's there. And you mean over a period of time that ensues, that's a microcephaly?
No, they will have macro, not micro. They will have had large heads.
Macro, large head. Oh, I
Yeah,
see.
they will have,
Yeah, that's what I was
they
trying
will
to
have large
clarify.
heads. Large, normal or large head. They will not be microcephalic.
Yeah, sorry, that's what I was trying to clarify. Maybe.
What also I have seen, they have large head and large body. They are macrosomic children, and somehow some of them, the pituitary is also suppressed. So pituitary should be followed up, because few of the patients, they have had pituitary insufficiency with this large cyst. So 2 patients who are always so obese, overweight, large head, intrahemispheric cyst, and they had pituitary issues. So that's something to.
I see. Sure. And as of now,
Because of the CSF pressure.
I see.
Dr. Namrata has shared a reference. So it was systemic literature review and for surgical treatment and clinical outcome in neurosurgery. Maybe that can be viewed, Dr. Pushan. It's
Yeah,
in the
sure.
chat.
I shall. Yeah, got that. Thank you.
But I think
most of the times
sorry, Dr. Naik, please go ahead.
Yeah, most of the times you don't need to do anything about it. Any practice. Sometimes they can be
Sorry, you're breaking up a bit. Sorry, what I got that is they don't need much intervention. If I understood, or maybe got that.
That's right.
Okay, I got it. Thank
you. Okay, so thanks, Dr. Pushan, for the case, and thank you everyone for your comments.
Thank you.
I think we're having some issues with Krishna Priya joining. Krishna Priya, are you able to join?
Yes, sir, I have joined.
Okay, great. Yeah, go ahead.
So this is a 4-year-old male child. He had a normal birth, transition and development, and a negative family history, no relevant past history. He presented with sudden onset.
So the timelines are in days. What is the x-axis?
Timeline is in days.
Okay.
So he presented with sudden onset severe headache, vomiting, and the headache was worst ever headache. The child was crying inconsolably. The mother tried paracetamol and NSAIDs, but the headache was not relieved with that. There was no triggering or relieving factors. And along with that, he had vomiting also. And the initial few days vomiting was there, which subsided with emisate. And then he had a mild swelling of the left eye. The severe headache persisted, and they went to a few hospitals with that. And in one hospital, he was started on methylprednisolone. And with the methylprednisolone, there was decreased, and the eye, there was mild to moderate swelling, which subsided. But by that time, he developed ptosis of the left eye, and there was new onset squint by that time. So this was around second to third week of illness. And he also had diplopia, and that progressed to complete ophthalmoplegia of the left eye. There was no other symptoms. By this time, the headache had completely subsided, and the child was left with left eye ptosis and left eye complete ophthalmoplegia. So he underwent a few workup, and he presented to us at around 40 days of illness. So this is after receiving the methylprednisolone. You can see that the right eye complete movement is there, and the left eye there is only slight movement present.
Okay, so I have 2 sets of scans. I'll go ahead with the imaging first. So the first scan was done on 7th February 2024, and you can appreciate correlating with the clinical finding. There is an abnormality in the cavernous sinus extending up to the orbital apex into the intracornal space. On the diffusion sequences, it demonstrates restricted diffusion. There is true restricted diffusion, as you can see on the low signals on the ADC sequences. The T1 non-contrast, it is iso-intense to slightly hyper-intense. T2 is slightly, again, hypo-intense to slight heterogeneity and hyper-intensity. Coronal sequences, again, you can appreciate the extension up to the cavernous sinus and also into the intracornal space. The flare sequence, non-contrast sequences, it is mildly hyper-intense. Again, it is predominantly involving the cavernous sinus and orbital apex and going up to the intracornal compartment. Post contrast, there is enhancement of the abnormality, the focal thickening out here, going up to the intracornal space, this orbital apex. I thought also there was some degree of enhancement of the bilateral optic nerves. Coronal sequences again better demonstrate the extent of the lesion. This is more internally into the intracornal space, going up to the cavernous sinus. And on the SAT sequences, this is the area of abnormality in the orbital apex next to the inferior rectus. Yeah, so these are the findings on the first scan. In the meantime, do you want anything in between, Krishna? I think the interval time is around 40 days on the first and the second scan.
Yes, sir. The interval time is so we want to know if there is any change.
So,
So
after the first scan,
yes, the child was so after the first scan there was a suspicion of lymphoma. So the child was the slides. The child underwent PET scan and it showed weakly metabolic nodes as well as the tonsils were hypermetabolic. So he underwent a surgery for the adenotonsillectomy. And the tissue was benign. There was no suggestion of lymphoma.
Okay, then there's a follow-up. The interval medication?
And during that time, the child was initially given IV methylprednisolone 30 mkd for 5 days. And after that, he was supposed to be on a tapering dose, but accidentally the child received only a very small dose of steroid. So he was on low dose steroid during this time.
This is after the MRI or before the MRI?
This is when the child presented to us around 40 days after the onset of illness.
Okay, I think that's the same video, no?
The movement was almost the same, yes.
Okay. So on the follow-up also, there is no improvement.
There is no improvement, but he never had the headache coming back after that.
Okay, so before we go into the discussion part, we have the follow-up MRI. And on the follow-up MRI, you can appreciate the progression of the abnormalities going more into the intracornal space. There's thickening. There's the dimensions also have progressed in comparison to the first scan. There is also some papilledema on the left side. Then, yeah, again, the coronal sequences, you can appreciate the extent up to the cavernous sinus, the lateral wall. But yeah, in terms of the lesion progression, there is the interval progression, slightly more heterogeneous on the ET2 sequences compared to the first scan. I think the second scan did not have any diffusion sequences, only an orbital sequence was done without diffusion. Contrast, there's no more heterogeneous enhancement. Suspicion of a thrombosis was, I think, kept, but only an angio was done. We could not appreciate any abnormalities on the angio. And this was the follow-up. If you can just...
So further workup was done to rule out the differentials. So ANCA, ANA, PANCA, and anti-TPO thyroglobulin came negative. ACL levels were done to rule out sarcoidosis. It was normal. Our radiologist mentioned that there was a lacrimal gland enlargement. So we did a IgG4, but this was done after receiving, this was done outside actually. It was normal. And a repeat was done here, which was also normal. Tuberculosis workup was negative. So course is the child received MPS and the headache responded, but the movements haven't responded to steroids. And in between, the child was started on a low dose of MMF, mycophenolate mofetil as well, but he has taken only for 2 weeks. So now he has no further headache. There is mild improvement in the third nerve muscles, and he is currently on methylprednisolone. So we were thinking whether to continue only steroid or there are differentials. Is it only tolosahund or we should work up for IgG related diseases or other disorders?
So based on the, I mean, at least the review, what the initial thought was on a meningeal tumor or schwannoma or neurofibroma, but they usually do not show any diffusion changes. The lymphoma was one consideration, which I think you have ruled out. The other abnormalities can be LCH, but the main concern was, could this be a rhabdomyosarcoma given the age of onset and also the progression and non-responsiveness to the medication. I don't have images, but I think a biopsy would be more suitable at this stage of time, at least in my opinion. But I'll open the case if anyone has any further suggestions.
Yes.
All right, in the chat, Tolosahand from Mandeep, Sridhar mentions that unlikely for Tolosahand, biopsy of rhabdomyosarcoma, Arpita also rhabdomyosarcoma, LCH, myofibroblastic tumors. So I think we're all going with tumor, high-grade tumor biopsy as the next step of evaluation. You want to add anything else, Arpita or Sridhar or Joy or anyone else? Arpita, if you have any experience as you work in the premier oncology center. Dr. Vijay also agrees with rhabdomyosarcoma. Yeah. So I think universally we think, Krishnapriya, the next step should be a biopsy.
Yes, sir. We will get a biopsy done though. Yeah, we were thinking it is Tolosa.
Yeah, as Arpita has mentioned, age group is little this thing, and
Yeah.
it's usually bilateral and more.
Alveolar kind of rhabdomyosarcoma, that's the type. It's not related to the alveolus. It's the type of rhabdomyosarcoma which are very aggressive and can grow very fast. And there is some perineural spread also in the cavernous sinus, I think so.
Yeah, there is along the trigeminal.
Yeah.
Okay, sir.
So yeah, I think biopsy should be done as soon as possible.
Okay, sir. We'll get it done. Thank you, sir.
Okay, right. Thank you.
Yes.
We are done with Geeta's case. Yeah, Dr. Ramya, if you're there.
Yeah. So, shall I present?
Yeah.
1 month old male child presented with abnormal movements since 11th day of life. So when I have seen the videos, they were very classical bilateral clonic movements, seizures. I don't know why the parents were not, I mean, they thought there were some normal movements, but they were occurring 2 to 3, sometimes 4 per day, like that. For 20 days they have occurred and then they have come. And predominantly it is starting from the left side and then generalizing to both the sides. Then on clinical examination, there were such linear hypopigmented patches present. And EEG was demonstrating right hemispheric onset seizures with right hemispheric fast activity. Otherwise, the child was feeding well. Antenatally, nothing was detected. Young parents, no other issues.
Consanguinity?
No, non-consanguineous couple. Okay. I wanted to discuss the MRI findings.
All right.
Nothing on the trunk? Any hyperpigmentation on the trunk?
No. Only this this linear pigmentation was there on the right side of the child, whole of this area, and whatever is seen in the picture, that much is there.
Along the blush lines? Not really.
Okay. Generally, in that Blaschko lines, we get that hyper and hyper. There is a linear hyperpigmentation.
Yeah, okay. All right. Okay, we'll go on to the MR. I think we're looking at possibly right hemispheric abnormality, and you can appreciate that the right hemisphere is completely dysplastic, also involving the ipsilateral deviate nuclei. So it's completely malformed. The right hemisphere has with the frontal lobes, perisylvian regions, the temporal lobes. There is some mild asymmetrical enlargement of the lateral ventricle on the affected side. There was no findings on the diffusion sequences, no other abnormalities on the other sequences. The SWS sequence also did not demonstrate any significant areas of blooming, but there is some tortuosity or prominence of the medullary veins and the transcerebral veins on the affected side, which can be associated with these malformations. On the midline Sag, corpusculosum from 1 month was normal, no midline abnormalities. Yeah, so the main findings are this right hemispheric malformation. What we thought was the hemimegalencephaly or right quadrantic dysplasia, and with the associated neurocutaneous syndromes can be activated by the mTOR pathway. These are the possible differentials, and given that the child has hyperpigmentation, possibility of hypomelinous of I2 to be considered. This was a paper published in Nature, I think in 2021. It has the largest series of the mTOR-related hypomelinous of I2 with neurodevelopmental abnormalities. They assessed around 71 patients, and 14 patients were identified with these Blaschko linear lines. And the main findings, at least in terms of clinically, were intellectual issues, epilepsy, macrocephaly, hemimegalencephaly in around half of the patients. Some of the images over here, not as statistic or as predominant as our child, but yeah, they can be associated with these hemispheric malformations. So we're thinking of hyperpigmentation of hypomelinous of I2 with the hemispheric abnormality on the right side.
Yeah, that was my thought also. My main doubt was, is there a significant, is there hemimegalencephaly? That was one doubt I had associated with the findings.
This will eventually develop into hemimegalencephaly because the entire hemisphere is involved.
Yeah, just in the lower cuts, I could see that the hemisphere is protruding towards the other side.
Yeah.
Apart from that, in the upper sections, I couldn't see. That was one doubt. And any experience of the other doctors with everolimus in such cases, mTOR inhibitors?
There was recently in this, I believe there was a in TSC, of course not in this, but in TSC they had given sirolimus very early in life. So maybe you could try.
There is a very good paper in Brain and Development on sirolimus. Yeah, for Strudge-Weber also and for TSC also. And they've given the protocol.
Okay, sir. Now, currently, the child that multifocal clonic seizures have gone with Gardinal and levetiracetam. But then child started developing this, the child will have a sudden jerk of the upper limbs and then a tonic contraction of both the lower limbs. Such other.
What is the weight of the child? What is the weight of the?
Weight of the child is 3.2.
Like he will benefit from hemispherotomy, right?
Yes.
5 kg. 5 kg they do it.
Okay.
No, we've done a recent one at 4 kg, 36, 45 days. 45 days, yeah.
Okay.
Okay.
So that's the best course.
Okay.
Yeah, that's the best course.
Should we try mTOR and then go for it, or
no? You have to save the developing brain. If they can do it, that's the best course. I hope sir will also agree with that, sir.
Yeah, absolutely. Yeah, there are risks in a very young baby, but basically of hemorrhage. But generally, they do very well. So we had 2 patients. One was 1 month and 1.5 months. The other one was about 4 months, and both did excellently.
Okay, sir. Now I have started topiramate. Any other better drugs, sir? Because of this tonic, I felt tonic kind of seizures.
Is this pre-surgery or?
No surgery. No.
The question is till surgery, what medication to give?
Yeah.
Yeah, vigabatrin. Yeah, that's a good option. Like for mTOR pathway, that's a very good option.
Okay.
It's just holding on till surgery, but keep convincing them for a surgery. It can So if they decided 2 years age and they decided 4 months of age, there will be a hell of a difference in the child's development.
Okay, okay,
Yeah.
sure. Okay, so Viga pattern can we start at this age? 1 month.
Yeah, of course, of course.
Yeah.
Okay,
No
sure.
problem.
Thank you.
Okay, thank you. To our next case, Dr. Puneet, if you're there.
Yes. Good
Yeah.
evening. So we have this. Am I audible?
Yeah, please.
Yeah. So 7-year-old girl, she was a developmentally normal child. So 45 days ago, she after 5 days of trivial febrile illness. So after the fever subsided, she developed focal seizures, which were more on the right compared to the left, and encephalopathy. And seizures gradually increased in frequency over the next 4 to 5 days. For initial 15 days of the illness, she was in another hospital where she received steroids, but there was no response. When she presented to us about 1 month ago, there was increasing frequency of the seizures, so she got intubated, required phenobarbital coma. And currently, we have been able to come down on the. We have stopped phenobarbital coma, but we have not been able to come down on the midazolam infusion. Whenever we come below around 10 to 12 microgram per kg per minute, she again has seizures. And in the EEG, there are multiple electroclinical seizures from the O1 and T4, T6 from multiple areas, electroclinical seizures. Her CSF autoimmune panel is negative. Serum autoimmune antibodies are also negative.
Puneet, sorry to interrupt you. Do you want me to show the images first?
Yeah, sure. Yes, sir.
So the images, the first image is after how many days of illness?
So this was done around day 4 or 5 of illness. This is of scan dated 14th of April.
Okay. So the images were slightly, the other sequences are not as clear as this one. So I have only the T2 various sequences, and then T2s you can maybe appreciate on the second image out here. Some medial temporal lobe abnormalities. So here you can see the amygdala is swollen, and also the thalami demonstrate bilateral hyperintense changes. The last two images out here, you have bilateral hyperintensities along the thalamus. In terms of malformation, could not appreciate any structural abnormality on these films. Mild cortical volume loss, but yeah, these temporal lobe abnormalities and thalamic abnormalities were standing out. I do not have a diffusion. So the first scan, I have only T2 sequences. Anything on diffusion mentioned?
So diffusion images which we got, the films were partially damaged, which was done in the previous hospital, but there was no abnormal diffusion restriction, which we discussed with our neuroradiologist here. There was no abnormal diffusion restriction. So they told that there is a bilateral medial temporal and the thalamic hyperintensities.
Yeah, and on this image over here, maybe superior temporal region. Also, if you see the contractile side, there is some hyperintensity there.
Yes.
But yeah, I think maybe maybe there's an abnormality out there too. All right, so then we have so yeah, this is the interval time.
We started 5-pentone coma, midazolam infusion. We have been able to achieve the burst suppression and stopped 5-pentone, but whenever we were trying to taper midazolam around below 10 or 12, she again has multiple seizures. She has received 1 course of methylprednisolone, 2 doses of IVIG, 1 plasma exchange was done, and she's receiving ketogenic diet at 4:1 along with 6 anti-seizure medication, which are going on their maximum doses. We had actually planned for rituximab versus tocilizumab, but now she has developed sepsis. Another feature was her anti-TPO was very high, which was around 4,000 with very high TSH, very low T4. So initially we thought that this could be a typical variant of Hashimoto encephalopathy, but she did not respond to the steroids. Today, we again repeated the anti-TPO antibodies in the serum, which is again very high, and we also repeated it into the CSF. So the CSF anti-TPO is also positive. So it is above the reference ranges which have been reported in the literature.
Okay. I have a follow-up scan, interval time, May 20th, so a month's time, I guess.
Yes, so this is around 3-4 days ago scan.
Okay. The diffusion, the diffusion sequences we're not able to make out without an ADC, which is if there is any restricted diffusion or not. Anything mentioned?
No. So they told the DWI and map were normal.
Okay.
Yeah.
Okay. On the flare, now you have progression, multifocal abnormalities, bilateral hemisphere, subcortical, cortical regions. Also, the periventricular regions have these hyperintense changes. There is interval volume loss, ventriculomegaly, thalamic. Again, you can appreciate it, bilateral thalamic changes. The basal ganglia also are slightly hyperintense. Brainstem also demonstrates hyperintense changes. So progression in terms of the imaging appearance, multifocal abnormalities, predominantly involving the white and gray matter structures. T2 sequences, I think FLAIR is best representative of the abnormalities. T2 demonstrates the interval volume loss, but yeah. So progression in terms of the multifocal abnormalities. Post contrast, again, I'm not able to make out the central areas, but do not appreciate any significant enhancement, focal enhancement of the abnormalities which we have seen. Optic nerves cannot make out on these images. So I think, as you have already mentioned, yeah, they were elevated anti-TPOs and their T4s were low.
Yes.
And thinking of
to be elevated in the CSF as well. So the anti-TPO in the serum is still in the thousands, and in the CSF, we just wanted to see whether this is just an association, this anti-TPO, or it like if it is positive in the CSF, it might give us the clue that it is involved in the pathogenesis. So it is actually positive in the CSF as well.
Okay, Dr. Vijay. Okay, Ramandeep says autoimmune encephalitis. MOG was, I think, tested as negative. CF is normal. Left sylvian. Let's see. Dr. Vijay asked for enhancement of the left sylvian region. Not sure, Dr. Vijay, if you can. If there is an enhancement or not. Are they just vessels?
From the discussion with the neuroradiology here, they told the enhancement is normal. Like there's no abnormal enhancement.
Okay. So I think clinical diagnosis you're working was Fires.
Fires not with very underlying Hashimoto encephalopathy.
Yeah,
but
so
the
usually
child has not at all responded to the steroids.
So Fires usually in the acute phase, they usually have diffusion abnormalities. I think in the chronic stages, the picture, as you can see in the lower panel, can resemble the case, but diffusion negative was slightly atypical. I think we had an Hashimoto encephalopathy discussed previously, had multifocal abnormalities, periventricular, predominant periventricular and deep central white matter abnormalities were seen. So if clinically it is a strong indicator, I think Hashimoto's encephalopathy to be considered as a possible diagnosis.
Dr. Nihaal, is there any possibility that these changes are secondary just to the refractory status which the child has, or do they look more like a inflammatory process suggesting that the underlying inflammatory?
Sorry. I think status would be more cortical. These are more, they have white matter and cortical involvement. So, and diffusion also is negative. So, I thought there's more inflammatory or autoimmune related rather than only status related changes.
Okay, yes.
Just a suggestion. If you see, the problem with this thyroid antibodies is very often a kind of epiphenomena, and it's very sure whether that's really the pathogenesis. The question is, of course, it points to an autoimmune condition. The other thing you could do is a PET scan. This PET scan shows very typical hypo and hypermetabolic, especially basal ganglia hypermetabolism, which suggests autoimmune, and maybe you can give him rituximab or something of that sort.
Sure, sir. Sir, regarding the next, because currently the child has sepsis, but she's improving. Her procalcitonin and CRP were very high. And also there was Acinetobacter in the bronchial alveolar lavage. So, for the next immunotherapy, what should we tocilizumab or rituximab? Which one would be a better option?
Well, if you're treating Fires, then maybe you should go with tocilizumab. But in the sense Fires, I'm talking about the Fires, is cytokine related. So one of the things you could do in that, but it's very difficult. If it's the autoimmune also, you may get changes in IL-6 and all in the CSF. So now it is done in Tata Hospital in Bombay, and it's very useful because there's a particular pattern in fires, IL-6, IL-8, and IL-10. And if you're treating an autoimmune encephalitis, I think rituximab would be the first choice because tocilizumab would be the third line therapy rather than the second line.
Yes,
But
sir.
all depends on. I think if you just send me your, I tell you where you can do it, and this
Sure.
I send you the name of the person.
Sure, sir. Another question, like, has anyone experienced this kind of straight or Hashimoto encephalopathy, which had a presentation like refractory, super refractory status and did not respond to the steroid? So whatever literature review we did, we found that the most of the patients have responded to the IVIG and methylprednisolone. Just
I
these
think
two.
you should forget about the TPO. This is
Okay,
not
sir.
important, right?
Yes.
Because often in fires patients, somehow in fires, GAD and TPO, somehow they come positive in significant quantities as well. I think of those 30, 50, or whatever I've seen, 25% will have significant TPO positivity. It's just a epiphenomena.
Yeah.
And you should just forget about it.
Sir, how will we explain low T4 and high TSH?
Hello?
Sir, Sridhar here. Sir, how will you explain to low T4 and high TSH? There is hypothyroidism.
There might be, but yeah, sorry. Yes, sir.
I had a question. Was there capping of the frontal horns on the flare, the second MRI?
Yeah, I mean, there is periventricular hypertendency.
I don't know how specific this is, but initially in fires you get, basically hypothalamic and pulvinar because of pulvinar increases involved in the thalamus because of status. And later on the capping occurs, and the capping actually is supposed to have a prognostic kind of, so if it's mild capping, they do better than those who have severe capping and atrophy and all this. So I agree with Vivek. This is probably fires only, in which case tocilizumab may be a better idea. I don't know. It's very difficult to do a IL-6 because IL-6 is high. Then I think it's worth doing. It comes in thousands.
Yeah.
Yes, sir. Yes.
I think if a fires child comes, like Ramya has just written her paper, I'm sure she's here, and we are hopeful that it will be published in soon. Our experience. So what we have found in a large series of patients that IVIG, cyclophosphamide, rituximab, plasmapheresis, they all fail. They don't work.
Yeah.
So what one has to do, the strategy should be now, if a child with fires comes, straight away sir is saying in a day or two, when you do the first CSF, do IL-6 levels. If the child, give methylpred, if the child is not improving and IL-6 is high, you should give early tocilizumab. If IL-6 is normal, we keep anakinra in our fridge because my rheumatologist also needs it. And we start that.
Where do you get it from?
So from Bangalore. So there is a company from which, so we have it in our fridge, we keep it, a stock. Because the amount of anakinra you have to give, the cost is similar to IVIG. You just need to give it for maybe a few weeks somehow if you can pass. Even the ketogenic diet is not helpful. So our strategy should be different and we should give intrathecal dex. This is how we should do for fires, straight away, as soon as the child comes. As for the midazolam, because again, the paper we had published, once you have reached a dose of midazolam where the seizures have stopped, the minimum dose, you convert it, as Romit had also mentioned, to enteral lorazepam 4 times a day. We found it beneficial. And some of my colleagues have told me that they also found it useful to wean off midazolam. These things, unfortunately, it's now 1 month into illness. I just feel nothing will work now. But this is what we should do when the illness comes to us at the start. Because I think now we are in the chronic stage.
Yes. Initially, when the child came to us, she already had Acinetobacter positive sepsis, required required high doses of inotropes to overcome the septic shock part. So that's why we went for repeat IVIG and plasma exchange and KD. Unfortunately, that has not worked as.
They will not work.
Yes.
Sorry, I shouldn't be so emphatic, but they don't. somehow, because it's a cytokine problem, it's not an antibody problem. It starts within few days of the infection, 1 or 2 days. So we have to have a different way of doing things. Cannot explain the hypo from, but it's not related to this type because they don't, Hashimoto don't present like this, refractory fires.
No, but is there a sick euthyroid syndrome or what?
But that should be euthyroid, right? So
Oh,
the T4 should be normal.
So the TSH is quite high, 174, with the T4 was very low, T3 was normal.
And is your TPO kit standardized for CSF also? Because that's
No,
also only a blood test.
Yeah, so we discussed with our biochemistry team. So they told this is not standardized, but if you want to get it done, we just wanted to get an idea whether if the because some of the patients from the literature they have been reported to have positivity, though it is not very specific. Positivity. Some patients who have CSF anti-TPO positivity, they may not have this Hashimoto encephalopathy.
Many of these patients also have anti-GAD positivity. So both are intracellular antigens.
Yeah, okay.
Yeah, okay then. Thanks, Dr. Puneet, for your case. Thank you everyone for this.
Thank you everyone.
I have 2 follow-up cases which were discussed during last meeting. I'll quickly just go through them. I don't think anyone from Rainbow Banjara is here, but this was a 9-year male child with history of headaches. For 5 days, and no other significant findings. There are also associated vomiting. On examination, there was chronic positive sign, neck rigidity, and deviation of the angular mode to the left. On imaging, you have these predominant left hemispheric abnormalities involving the white matter, the deep brain nuclear structure, the central white matter, also involving the cortex and white matter structures of the temporal lobe, basifrontal regions on the, again, left more than right. There were no changes on diffusion, no significant change on diffusion, no SW abnormalities, some mass effect on the ipsilateral ventricle. Contrast, there was no significant enhancement on both contrast studies. Spectroscopy demonstrates some degree of protein elevation with reduced NAA peaks, mild elevation of the lactates. We thought of gliomas as one of the possibilities. Again, inflammation was another consideration. Biopsy was done, and on the biopsy, this was the final impression: diffuse low-grade glioma of the left hemisphere, and next generation sequencing was suggested. Yeah, so that's the follow-up of that case. If anyone wants to add any comments to it. Okay, yeah. And then we have another case. I think Dr. Vivek also had discussed this in the last meeting. Dr. Vivek, you just want to quickly summarize the presentation of the child. This is the one
There's
with
a 4-year-old girl who had 6 months prior to the presentation, history of a febrile illness, following which she had recurrent vomiting in the mornings, cerebellar syndrome in form of a broad-based gait, truncal ataxia. She had a sibling who had died at around 2.5-year age, who had a similar presentation, who had recurrent fever from 2-month age. And during the febrile illness at 2.5-year age, again lost balance, unsteady, and died in an infection, had pancytopenia, that sibling, not this child. So the workup had revealed posterior uveitis, so we were sort of led into sarcoidosis, neurosarcoidosis, and this was the MRI.
The MRI, I think we'll directly move on to the T2 sequence. We have multifold abnormalities in the supratemporal brain, white matter, gray matter structures, also predominant cerebellar involvement on both sides, brainstem involvement. Post contrast, we have these nodular, cloudy or linear type of enhancement, predominantly again in the cerebellar hemispheres on both sides, some nodular enhancement in the supratemporal brain. Then we thought of, given the family history and the imaging findings, especially in the posterior foci, HLH is one of the possibilities. Other considerations were lymphomas, sarcoids. Demyelination was down on the list, but yeah, to be considered LCH, again, another histiocytic spectrum disorders. Child was evaluated. I think these are the main investigations done. Exome sequencing was sent. Again, sarcoidosis was a consideration, but the exome sequence revealed up to it.
Yeah, so exome revealed HLH.
Yeah, only I think we were between HLH and sarcoidosis because of the non-cascading, the histopath appearance was of non-cascading granulomas.
Yeah, the thing with HLH, if we look at the report, the genetic report, we do struggle with primary HLH, especially when the CNS involvement is there, because we don't have a peripheral manifestation often, especially even the ferritin and the other markers. So what I've been told by my neurology colleague, that if we do a perforin assay, that picks up 40% of the patients, 60% of the patients. And if you do a leukocyte degranulation assay, that picks up around 30. So 90% of patients of primary HLH can be picked up by these two assays. And one of them costs 4,000 rupees and the second one around 4,000-5,000 rupees. It's available in PGI Chandigarh, both of them. Perforin is easily available. Leukocyte degranulation is available in PGI. You need to process in 24 hours. And it's also available in Lal Path Lab. So it's just if one suspects primary HLH and where one is still waiting for the genetic report to come, these two assays could be done to get the results early, because they will